So this is my third presentation or third mini lecture about the lung-kidney interaction in disease, and in this presentation I will talk about the renal complications of obstructive airway disease. We all know that obstructive airway disease is one of the categories of important categories and common categories of chronic lung diseases met with in clinical practice, because they are more or less related to environmental pollution and to bad personal habits, especially smoking or cigarette smoking, being the most important underlying cause of chronic obstructive airway disease in adults. And the range of COPD, of course, includes both emphysema at one end of the spectrum and the chronic bronchitis at the other end of the spectrum, and in between there is an overlapping different clinical phenotypes of chronic obstructive airway disease. And there are two major classic clinical phenotypes in practice: the pink puffer, in which emphysema is predominant, and the blue bloater type, in which the chronic bronchitis is predominant, causing blue because of central cyanosis, bloater because the patient is bloated edematous. So, and here is the predominant chronic bronchitis. In the first one, I said the predominant is emphysema causing pink puffer, pink because of the secondary polycythemia, and puffer because of the puffing patient due to dyspnea, because in emphysematous cases the dyspnea is the predominant presentation, while in chronic bronchitic predominant type of COPD, cough and sputum is the commonest clinical presentation. It is cough and sputum, production of yellowish sputum or white yellow sputum for at least 3 months, for at least 2 or more successive years. The definition of chronic bronchitis. Cough and sputum is the predominant presentation, while in emphysema, dyspnea, that is shortness of breath, whether at rest or with effort, is the predominant presentation. Whether in COPD or the chronic bronchitis or in emphysema, COPD in general might be complicated by, as we all know, acute exacerbations, exacerbating COPD with acute infections on top, especially in the winter in such cases, and these exacerbations might cause cor pulmonale, that is affection of the right side of the heart, complicated or complicating chronic obstructive airway disease, that is right ventricular pathology complicating chronic obstructive airway disease. And when the right ventricle is affected, it might be complicated later on by right-sided heart failure, and of course with all the manifestations of right ventricular failure. And among them is systemic complications, including the congested hepatic enlargement, the congestive hepatomegaly, the congested veins, the edema, and of course it might also affect the kidney due to systemic venous congestion. So there might also be proteinuria, and there might also be a microscopic hematuria in such cases, and in advanced cases also they might be complicated by some sort of nephrotic syndrome. And in advanced cases of congestive heart failure, we might get also even some sort of chronic kidney disease, which may even evolve into renal failure. Another sort of renal failure in such cases is the acute heart failure complicating, or the ventricular failure complicating COPD due to the metabolic due to the acidosis which is met with in such cases, and also due to the hypoxemia, which is common in such cases. These are factors which affect the heart directly, indirectly, and they might cause left ventricular dysfunction. So the heart failure also, and in addition to the right-sided affection with vomiting due to congestion of the GIT and the loss of appetite, we might get many factors which predispose to what we call pre-renal acute renal insufficiency. Pre-renal acute renal insufficiency. And of course the pneumonias which might complicate even the COPD, they themselves cause renal complications and renal pathology. So the COPD might cause renal manifestations of renal pathology by many different mechanisms, by congestion, by hypoxemia, congestion due to cor pulmonale and right-sided heart failure, by hypoxemia, by systemic inflammatory reaction, by endothelial dysfunction, by causing pre-renal acute renal failure due to factors including dehydration, including acute heart failure, including vomiting, etc. In addition, of course, to the effects of some drugs taken by such patients. So all of these factors, they share in the pathogenesis of renal pathology and renal clinical manifestations in patients with obstructive airway disease. Another category is the renal complications in interstitial lung disease, and I mentioned part of it in my first presentation. Interstitial lung disease is another category of chronic lung diseases characterized by inflammation and scarring of interstitial tissue, and they are caused by a wide array of diseases, medications and environmental pollutants which affect and damage interstitium of the kidney, and they will directly affect what we call the alveolo-capillary membrane, and they cause primarily what we call diffusion defect, unlike obstructive airway disease, which causes what we call obstructive hypoventilation. So it is a ventilation defect in obstructive airway, while here in interstitial it is a diffusion defect because it affects the alveolo-capillary membrane, as the pathology affects the interstitium with scarring, and this will affect the diffusion of gases, especially oxygen, and also the exchange with carbon dioxide. So there is insufficient oxygenation of the arterial blood, and we get hypoxemia. The hypoxemia of interstitial lung disease, it is one of the pathogenetic factors or mechanisms involved in the pathogenesis of renal complications in patients with interstitial lung diseases, as they might cause tubular defects, it might cause glomerular injury, and this also might, on the long run, cause a chronic kidney, some sort of chronic kidney disease in patients with interstitial lung disease. So this is indirectly. In addition to the fact that some systemic pathologies which cause interstitial lung disease, they might also involve the lungs. So here is the concomitant affection of both the lungs and the kidney by the same pathology, like what happens in connective tissue diseases, in some autoimmune diseases, especially vasculitic syndromes, as exemplified by the microscopic polyangiitis, which involves the lungs by interstitial lung disease, and also other causes of interstitial lung disease which might involve the kidney also by the same pathology, like patients with systemic sclerosis, like patients with mixed connective tissue disease, like patients with Sjogren's syndrome, like some patients with rheumatoid, although rheumatoid usually affects the kidney through its drugs, not by the disease process itself. It is the drugs used in rheumatoid which affects the kidneys. And we all know that rheumatoid, it affects the lung also by rheumatoid nodules and Kaplan syndrome, and by causing bronchiolitis and interstitial pneumonitis in many cases with rheumatoid disease. So these are causes which might involve the lung and the kidney at the same time, concomitantly. Although the presentation may be clinically different in time, they might not present clinically at the same time. They might be weeks or months before the different or the two presentations, but ultimately they will concomitantly affect the two organs, the lungs and the kidneys. So this is here the lungs and the kidneys being involved in systemic diseases causing chronic lung pathology, and at the same time chronic kidney disease ending into chronic lung damage and chronic kidney damage. So this is in systemic diseases, chronic lung and chronic kidney involvement in systemic disease, especially in autoimmune diseases and in the vasculitic syndromes. A third possibility is the suppurative lung disease I mentioned, and the commonest complication of suppurative lung syndromes or suppurative lung disease, especially the bronchiectasis, is the bronchiectasis-induced secondary amyloidosis, and the amyloidosis is one of the systemic diseases which might involve the kidney, and they cause nephrotic syndrome, of course, and this is one of the common systemic causes of nephrotic syndrome, amyloidosis. And amyloid will cause nephrosis, and then the nephrotic in advanced cases will progress into chronic renal failure. So whether nephrosis or chronic renal failure, these are ultimate chronic complications of chronic suppurative lung disease due to secondary amyloidosis. So the link here between the chronic lung disease, which is the chronic suppurative, and between the chronic kidney disease is the secondary amyloidosis, as what happens in bronchiectasis induced amyloidosis, and amyloid involve the kidneys with its renal sequelae, as I mentioned. So this is the suppurative lung disease and the kidney, the COPD and the kidney, the interstitial lung disease and the kidney, mainly through hypoxia, systemic inflammation, which is common in such lung conditions, chronic lung conditions, and the endothelial dysfunction associated with such chronic lung diseases causing renal impairment and insufficiency and even failure. This is, in short, how does the chronic lung diseases affect the kidney pathologically. Thank you so much and have a nice day.